Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Rylan Johnson. Dr. Johnson is board certified by the American Board of Foot and Ankle Surgery and Reconstructive Foot Surgery, as well as Reconstructive Rear Foot and Ankle Surgery, and a local. I love having you locals on the podcast. You're just 30 miles away, right? Were you born and raised in Sturgis, or just went to high school there?
I went to high school there.
Okay.
Yeah, I was actually born in the Spearfish, Belle-Fourche area. My dad was from Spearfish. My mom was from Belle-Fourche.
Then how did this particular profession call to you, Dr. Johnson?
Well, it's a good question. I've always wanted to kind of go into healthcare. Mm-hmm. I was even a nurse's aide out at Fort Meade when I was in high school. And
so it's in your blood then. I mean, you were ready for this.
Yeah, it was something I always wanted to do. And so I worked as a nurse's aide at Fort Meade through high school and even through college. So I've always had an interest in healthcare. I met some podiatrists that were actually some business associates of my father's in California, and they introduced me to the field and just kind of took a knack to it.
And we were talking a little bit beforehand, and hopefully we'll get into it a bit here with a topic that we want to talk about today. But the foot in particular seems to be pretty underrated, I think, on our body, right?
Right, I would agree with that.
So many people take it for granted. And I'd also mentioned that we want to talk about bunions specifically in this podcast, and Lapiplasty,
right,
which is a procedure that can correct them.
Correct.
And so, again, looking this up and doing a bit of research on it today, I didn't know how interesting the whole thing was going to turn into, and then it really, really did. Bunions specifically, I think, is a subject that all of us are familiar with.
Right.
You probably have, I would say, maybe somebody older in your family that would have this condition, right? So let's just start with what a bunion is, doctor.
Right. And bunions, we find that 25% of adult Americans have bunions, so it's a very common problem. But it happens in kids too. I've done lab.
Really?
Yeah, it does. Juvenile hallux valgus is a thing for sure. I've actually seen young kids that I have to wait till their growth plates fuse before we do surgery on them. So
okay.
I think the youngest I've done is a 13-year-old girl. So it's congenital, and it is something. It's not something. I mean, it traditionally develops and gets worse over time. But there are some young people who have juvenile hallux valgus that they have it very early on in life.
Okay. So what is happening with that bone there? Because it's very easy to notice somebody that has a bunion.
Correct. Yeah.
Because it looks like that bone just juts out into a V shape on the side of your foot.
Yeah. So it's kind of the angulation of the first metatarsal in relation to the toe, which is the proximal phalanx of the great toe. And if everything lines up correctly, all the metatarsals should line up rather parallel with one another. And in which case, the big toe joint or the first metatarsal phalangeal joint is congruent. The toe is straight. When there gets to be a lot of hypermobility or laxity in the joint at the base of the metatarsal, which we call the metatarsal cuneiform joint, you get rotation and movement at that joint. And a lot of that rotation and movement is kind of pathological, in which case it kind of tends to deviate outward. But it can also kind of elevate and rotate as well. So a lot of people with kind of these larger bunions, it's really a triplanar deformity, which can cause more pronation and it cause increased stress on other parts of the foot because the first metatarsal is not biomechanically stabilizing the foot in the arch.
So all of those bones in your foot that make your toes they're all similar, aren't they, to that big toe? Why does it only happen there?
Right. The big toe is kind of special.
Okay.
Yeah, for sure. It's different than the lesser metatarsal phalangeal joints. The big toe actually has two extra bones called sesamoids. They're kind of like kneecaps for the joint, and they kind of help with mechanical advantage of the joint. And when the metatarsal does translate medially, those sesamoids tend to rotate or sublux out of position as well. And so the biomechanics also tends to pull the toe out of joint as well. So, yeah, the lesser metatarsal phalangeal joints really mechanically are far different than the medial column.
So, is this something that you can be born with, or does it generally happen Just like, I know you said you had it in some of these
I do
youngest
think it's
12 or 13,
congenital.
but okay.
I do think it's congenital. I don't think it's caused by shoes. A lot of people feel like, I had poor shoes when I was a kid, things like that. But I think you have more of a genetic propensity towards developing bunions. Now, shoe gear can make it worse. One of the main ways that I think people treat their bunions is to find a wider shoe to take pressure off of the prominence of the first metatarsal. And so tight-fitting shoes can make a bunion more symptomatic. But I don't think it exacerbates or makes the condition more pronounced, if you will.
And I kind of remember growing up hearing when people talked about bunions, women specifically, about high-heeled shoes.
Right.
Is that a myth, or is that kind of true?
Well, once again, I think the shoes tend to make the bunion worse, for sure.
Okay.
Now, I do find there's a greater propensity towards developing bunions in women, or at least I see a lot more of them. I think women are a little more hypermobile than men are, so I think that first-rate hypermobility is a lot greater in the female population. And I also think men don't mind wearing big, bulky shoes, So,
right. We're not into fashion.
Yeah, as a guy,
matter.
we can wear a tennis shoe or a wider toe box shoe, in which case our bunions have a little bit more room and there's less pressure on them, whereas women are more resistant to those types of shoes.
Right.
So.
Okay. Can you prevent this at all, even if it's congenital? Can you prevent a bunion from happening?
I don't think so. I think trying to wear orthotics might help with the positioning of the foot and alignment of the joint, and I think some patients feel like foot position with an orthotic might help the biomechanics of the foot, but it doesn't correct the bunion, nor do I think does it dramatically reduce how quickly it presents itself.
So if you're going to get it, you're going to get it.
I think that's accurate.
So let's say that you finally have it, and this is so interesting too, because when I knew we were going to have this conversation, all of a sudden on TikTok of all places, which is just terrible for misinformation in a lot of instances, I was seeing this device that these people were saying you just kind of attach it to your big toe and a little screw on the end will push that. Right. That's got to be BS, doesn't it?
And a lot of these things are splints, and and a lot of times these deformities are manually reducible. Really, when they're very hypermobile, I can even with my thumb kind of reduce the deformity and have it come back. So I do think some splints can hold the toe in position, but and that might even alleviate a little bit of soft tissue strain if things are kind of symptomatic. However, once you take the splint off, the deformity will recur.
So it is not a fix.
It's not a fix
at all.
No,
okay. Well, let's talk about something that can be then, which this is a pretty fascinating surgery. And again, I encourage people to look it up and watch the animated videos of it if you can't handle the actual surgery on somebody's foot. But it seems so, again, minimally invasive. It's called Lapiplasty.
Yes.
And I'm going to let you describe how it works, because first question. The first thing I noticed when I was watching the videos and researching it a little bit is they kept saying 2D and 3D.
Right.
Okay? Can you start there with this?
Right. So previous bunionectomies, we were kind of focusing on addressing the deformity at the metatarsal head, metatarsal shaft, where we were making what we call an osteotomy. And an osteotomy is where you make a bone cut within the bone and then reduce the deformity by translating the bone cut.
Is that right at the bump of where that?
It can be.
Okay.
Yeah, it can be either at the bump, which would be kind of what we call a metatarsal head osteotomy, which would be the most common previous bunionectomy we did, or a chevron osteotomy, or you can do a mid-shaft or a closed. There's lots of different ways of approaching that, but the translation correction was oftentimes 1 to 2 planes of correction. Very rarely can you get rotational correction with an osteotomy, and we're talking kind of more of a frontal plane rotation.
So when they're talking the 3D, they're literally meaning it in a 3D sense.
3 planes of correction.
Yes.
Right.
Okay.
Yeah. So with Lapiplasty, we reduce the deformity first, and we always focus at the metatarsal cuneiform joint, because that really is the center of rotation and the apex of the deformity, which makes sense. I mean, this procedure just makes sense. I always kind of say it's kind of like that your metatarsal deviating is kind of like the Leaning Tower of Pisa. And if you're wanting to bring the Leaning Tower of Pisa back up into a rectus position, you probably should go to the foundation or a home, for instance. If you see a home tilting over, you don't go look at the second floor as to where the problem resides, right?
Yeah.
You actually go to the basement. You go to the foundation. And that's what Lapiplasty focuses on, is actually correction at the center of rotation. And so that's why we go to the base of the metatarsal at its joint at the metatarsal cuneiform joint. And that's where we make our correction at that apex. And when we correct that, we correct that in the dominant transverse plane, which is where the bump kind of goes away. But there's also some sagittal plane plantar flexion, which kind of tends to stabilize the arch. And we can also get rotation. And that's the third plane of correction, is that rotation of the metatarsal. And with the rotation, we can kind of realign the sesamoid apparatus, which are the two little bones that kind of reside underneath the metatarsal. They're kind of like kneecaps for the joint. And with that rotation, we can get the sesamoids put back into position as well, which helps biomechanically and function of the joint.
Well, now I noticed in that procedure, and I think at the base there, I think that you're talking about, you make you kind of shave out two like pieces of bone there, don't you?
Correct. Yeah.
Why?
Well, that's how we get our correction. So, what we do is we kind of correct the deformity, and that joint will gap because the joint is kind of has an oblique angle to it. Okay, there's motion there, but when you correct that, it does open up and gap, and so that's where we actually need to make our cuts. And traditionally, this Lapidus bunionectomy Lapiplasty procedure, we make a flat cut on the cuneiform, and we use a cutting guide with Lapiplasty. I think that's also kind of important to kind of discuss.
The tools are amazing.
Yeah.
When you
So
watch
the technique is what made Lapiplasty kind of what it is. So our reduction, 3 planes of correction. The cutting guide is placed at the center of rotation at the joint, and the cutting guide literally kind of tells you where to make the cuts to capture the correction that you currently have on the table. So you get your correction first, you like the positioning, you stabilize it, then you place the cutting guide in place, and the cutting guide tells you where to make your cuts to capture that correction. So it's a very reproducible procedure. It kind of takes a lot of the subjectivity out of it, because when I used to do Lapidus before Lapiplasty, which is what, Lapiplasty is a Lapidus bunionectomy, we used to make those cuts by hand, okay?
Oh, wow.
Yeah, we would estimate our cuneiform cut as being a flat cut and then do a parallel cut on the metatarsal. However, there was some subjectivity involved, right? You were just making those cuts by hand. So, you were always kind of looking at things, planing things down, kind of a lot of woodwork, if you will. But with a cutting guide, it really takes a lot of that subjectivity out. And so, the cutting guide makes those cuts. You remove the joint, which does stabilize the foundation of the building, and then you can compress that down. And you're actually getting a fusion of that joint, of the metatarsal cuneiform joint, and that's what gives you really also long-term correction.
Yeah.
Because if you think about the Leaning Tower of Pisa, if you don't stabilize the foundation, or if you just correct the second floor, the foundation will continue to migrate. Right.
Well, and there's also there's 2 little plates that go in there as well, isn't there?
Yeah, and that plating system really is also proprietary towards Lapiplasty, called biplanar plating. And the dorsal plate is kind of placed right on the top, and then we kind of go 90 degrees to the inside where we place another plate. And we kind of find that placing that plate in place makes a very stable construct that actually allows patients to bear weight early, okay?
And get you moving faster.
Get you moving faster,
yeah.
Right. Where previous Lapidus before Lapiplasty, the restriction in weight bearing was 6 weeks non-weight bearing. It was kind of non-negotiable. And then you were it was always 6 to 8 weeks, and then you were in a boot for another month out of that. It was almost 3 months before you were in a shoe. But with Lapiplasty, we can almost bear weight immediately. I definitely have patients walking at 2 weeks. They're ambulating in a boot, and I get them out of the boot at 6 weeks. So we're not only allowing patients to bear weight and walk almost immediately, but we're getting them into a shoe at the time that previous patients were just beginning to bear weight. So it's a much faster recovery, reproducible results. It's
what's the success rate of it then generally?
Well, honestly, the success rate, that's a good question.
Sure.
I'm not sure if I have numbers on that.
Sure.
But it's, I found it to be a very successful procedure.
Yeah. It seems like it. It seems like there's not a lot of ways that it can really go wrong once it's been fixed, I suppose.
Well, and I think that if there is complications, everything has complications.
Of course.
Every procedure does. But, we are fusing a joint at the metatarsal cuneiform joint level. However, non-union rates at that location are less than 3%. Where if you compared that to previous Lapidus bunionectomies where we had 2 screw constructs or a screw and a plate, we always said non-union rates around 8 to 10%. So we do have a better healing rate with Lapiplasty, and I think that denotes to the biplanar fixation. It's very stable fixation. We get better unions with those as well. So not only can you bear weight sooner, but you also have a much better rate of healing as well.
Now, I'm assuming the reason why people want to have this done is because it's painful. It must be painful
yeah.
in a sense.
Yeah.
Are there bunions that aren't painful that you can just live with? Are there some
I usually
that
don't see them.
Yeah, okay.
Probably are.
Maybe. Well,
Yeah.
I suppose,
Yeah.
I can't imagine
Yeah.
how it couldn't hurt or just be
Well,
uncomfortable.
yeah, and I think a lot of times people just turn to live with them. You
Yeah.
know, and I think that's quite a bit of it is that people do tend to just live with them where, you know, they're okay with wearing wider shoes or making changes in their lifestyle or activity in
Right.
accommodation for the bunion. I mean, sometimes people can change their lifestyle. However, you know, if those things aren't agreeable, then I think those people seek care.
Yeah,
right?
get it fixed. No kidding. With a
Right.
procedure like this, and after spending a little time with it today, and you know, are you one of the few here around that does this procedure too?
Yeah, my residency director in Colorado was part of our research and development team for Lapiplasty.
Oh, wow.
There were 8 physicians that were put together as kind of to put together the R&D of Lapiplasty.
Yeah.
And my residency director out at North Colorado Medical Center was one of those physicians involved with that. And that was based on some research that we had done when we were in residency, or my co-residents did as well. So I kind of I got introduced to it pretty early on through him. And I was the first person in South Dakota to do one.
Oh, that's very cool. Yeah.
Yeah. So I was, and I've definitely I've done, I think according to the website, I've done over 300 of them at this point in time.
Oh, really?
Yeah.
So you're pretty good at this then. All right. Excellent. Dr. Rylan Johnson, thank you very much for coming in and talking about this. It is, the technologies that keep popping up in medicine and in surgery, they have to get exciting for you. What could be next with this? I mean, what could be the next thing they do, or is this a surefire way to fix it? And, you know, this will be the thing that we use for decades to come.
It's a good question. You know, like I said, Lapiplasty is a Lapidus bunionectomy, which has been around for quite some time. And we've always liked Lapidus because of the low recurrence rate. When you fuse that joint, the recurrence rate is like less than 3%. Whereas doing a distal first metatarsal osteotomy, research has shown that, you know, recurrence was up to 70% after 10 to 15 years. And that makes sense.
Yeah.
If you don't stabilize the foundation, the building continues to tilt, right? You can realign the roof line, but it'll continue to migrate. So I think Lapidus has always been a really great procedure over the years, and I had done it before Lapiplasty as well.
Okay.
I've kind of taken it on just because a lot of the things we didn't like about Lapidus have been addressed. The early weight bearing, the better healing rates. I don't find that there are any more cons with it anymore,
Sure.
and it's a really great procedure. The techniques is, you know, really kind of where it is. I think Lapiplasty's technique with the triplanar correction, the biplanar fixation, I think those are the things that are making it as popular as it is. And those are the reasons why I have taken it on and continue to do it. And it's really the only bunion I do nowadays.
Oh, excellent.
So I've done lots of other ones over the years. I kind of just converted to Lapiplasty because I find it hard to come up with a reason not to.
Right, sure.
But yeah, I'm sure they're coming out with some new things. But yeah, the cutting guys, I think, and everything, I think, is what made this as popular as it is.
Excellent. Dr. Rylan Johnson from Monument Health, thank you for coming in and talking about this. It's been fun. You bet.
Thank you.